Right now is the session for the modern radiation, the modern hypofractionated radiation. And today we have Dr. Grace. She is Senior Consultant, Radiation Oncology Department of Mount Elizabeth Hospital. I'm honestly requesting Dr. Grace to come to the dais and give her speech. Dr. Grace.
Good afternoon, everyone. Okay, first of all, I would like to say thank you to the organizing committee for inviting me to be here. And also thanks for everyone to be here with me at this time. So our topic today is hypofractionation in breast cancer. So we all know that globally, breast cancer is the number one cancer among females. And even in many countries, is still among the top 10 of the death from cancer. And also, we are all aware that the mainstay of the curative treatment in breast cancer is surgery. So after lumpectomy, and in some cases of mastectomy, adjuvant radiotherapy is required. So you can imagine the incidence of breast cancer, how many patients are there that require radiotherapy. So at the very beginning in 2002, so there is BBCC, that actually this trial is testing whether breast conserving surgery plus radiotherapy is equivalent with mastectomy. The radiotherapy used here is 50 Gray in 25 fraction over 5 weeks. And yes, this trial shows that breast conserving surgery plus radiotherapy is appropriate treatment for breast cancer. So imagine in that 5 weeks and the 25 times, our female patients who are women, meaning they are mothers or daughters taking care of elderly, or mothers taking care of their children, or they work in the office, they have to come back and forth to our radiotherapy center 25 times for 5 weeks. That disrupts their lives. And imagine they may not even come from nearby. Our radiotherapy center may not be near where they live. So they still have to come, move, and stay in their other city for 5 weeks and find a replacement also to replace their role in their home. So imagine the time, the cost required, and the effort for them to cure their cancer. Is there anything that we can do to actually help them that? Number one, how to reduce the cost is not only the cost of the logistics for them, but also the treatment cost itself. That's why hypofractionation is important, and also the time required for them to come to the radiotherapy center. And also with hypofractionation, we can free up some slots earlier, which means treatment can be started earlier and completed also earlier for them, meaning they can go back to their life sooner. So at the start, there is start A and B. In 2013, the UK did a trial in 35 centers. Start A actually testing the 50 Gray 25 fraction with 2 other regimens, 41.6 and 39, and start B comparing with 40 Gray 15 fraction, which at that time was already started to be adopted among UK centers. After about median follow-up 9 years, the start A shows that 10 years local regional relapse among the 3 regimens are actually non-significant statistically. And there is even moderate marked breast induration, telangiectasia, breast edema that are less common in the 39 Gray regimen compared to the 50 Gray. What about start B? Also similar median follow-up, about 9.9 years, there is 10 years. Local regional relapse, also comparable between 50 Gray and 40 Gray. Breast shrinkage, telangiectasia, breast edema were even significantly less common in the 40 Gray. So since then, we start doing the 40 Gray and 15 fraction according to the START trial. Similarly, in Canada, in 2010, they are testing 50 Gray 25 fraction with 42.5 Gray in 16 fraction. At 10 years, local recurrence are similar, and good or excellent outcome, also comparable among the 2 regimens. So there, 10 years after treatment, accelerated hypofractionated whole breast irradiation using 42.5 gray in 16 fraction was not inferior to the standard treatment, the 50 gray. So we moved on from 25 fraction to 15 fractions. We already actually cut down 2 weeks. Can we cut down even further? Can we compress even better? And while doing so, still doing so safely. So fast forward to the Lancet 2020, when the UK did a trial among 97 centers from 2011 to 2014, comparing 40 gray and 15 fraction to 2 other regimens. Both are 5 fraction, but one is 27 gray and the other one is 26 gray. Primary endpoint is ipsilateral breast tumor relapse. Secondary endpoints, late adverse events, and other survival outcomes include PT1 to 3 and 0 to 1 M0, BCS or mastectomy, SLNB or axillary lymph node dissection. Nodal RT was not allowed. Concurrent systemic treatment is allowed for endocrine treatment and Herceptin during the radiotherapy, but not concurrent chemo. Sequential boost is allowed, 16 gray in 8 fraction or 10 gray in 5 fraction whenever necessary. So median follow-up is about 6 years. Ipsilateral breast tumor relapse, there are 79 to be exact. So 31% versus 27 versus 21. So actually, they're comparable, they're equivalent. Most common cause of non-breast second primary cancer is colorectal cancer. And yes, what about the cardiac? We always worry about that, especially when it's the left side. So out of 27 cardiac-related deaths, actually only 15 had already history of cardiac disease or they were smokers. So here, this table, I just would like to show that the secondary endpoint, incidence of local, regional, and distant relapse, disease-free survival, overall survival was similar in all groups. No statistically significant difference. And what about normal tissue effect between 27 gray and 26 gray? So yes, in 27 gray, there is higher normal tissue effect, but not in the 26. So at 5 years, moderate or marked clinician normal tissue effects, in breast or chest wall, compared to the 40 gray, 27 gray is 14.4%, whereas the 26 gray is only 11.9%. And across all clinician assessment from year 1 to year 5, there is significant difference with the 27 gray, but not the 26 gray. Therefore, 26 gray in 5 fraction over 1 week is non-inferior to the standard of 40 gray in 15 fraction over 3 weeks for local tumor control, and is also as safe in terms of normal tissue effects up to 5 years for patients requiring adjuvant local radiotherapy after primary surgery in early stage breast cancer. Is there another way of doing it fast? So this FAST trial in 2020 is testing in 18 centers, recruiting from 2004 until 2007, female 50-year-old and above, small tumor, maximum 3 centimeter, and 0, and lumpectomy only. They're comparing 50 gray 25 fraction with 30 gray 5 fraction weekly and 28.5 gray in 5 fraction weekly. Just now fast forward 5 fraction daily. Fast is 5 fraction weekly. Primary endpoint, change in photographic breast appearance in 2nd and 5 years. Secondary endpoint, normal tissue effects and local tumor control. Median follow-up, 9.9 years. 11 ipsilateral breast cancer event, 3 versus 4 versus 4, 96 deaths, also comparable among all 3 regimens. At 5 years, about 80% had no change in photographic breast appearance, and only 17.7% had mild change, and even less actually had marked change. The rates of mild or marked change in photographic breast appearance at 2 or 5 years were statistically significantly higher for 30 gray than for 28 gray. So then for any moderate marked breast normal tissue, shrinkage, induration, telangiectasia, edema, again 30 gray is significantly different compared to the 50 gray, but not the 28 gray. So therefore, at 10 years, there's no significant difference in normal tissue effects after 28.5 gray in 5 fraction weekly. So now we have already compressed the number of the radiation itself from 25 to 15 to 5, but we are still talking about whole breast irradiation. What about also reducing the area of the radiation? Can we talk about partial breast irradiation? So UK import load trial, looking at this, recruiting patients from 2007 to 2018 in 30 centers, comparing 40 gray 15 fraction whole breast versus 40 gray and 15 fraction partial breast. Eligibility, 50-year-old and above, and has to be ductal carcinoma, unifocal, maximum 3 centimeter tumor, margins at least 2 millimeter clear, and no lymph node. Primary endpoint, ipsilateral local relapse, median follow-up 72.2 months. At 5 years, local relapse cumulative incidence are similar among the two arms, 1.1% versus 0.5%. Statistically significantly lower adverse events for the partial breast in terms of change in breast appearance and whether the breast feels harder or firmer. Therefore, partial breast irradiation is non-inferior compared with standard whole breast irradiation in terms of local relapse in this group of patients. Okay, is there any other way doing accelerated partial breast irradiation? So we already shrink the area, can we also do it accelerated? So in Florence, from 2005 until 2013, in this one single center, they did a trial, older than 40-year-old women, tumor maximum size 2.5 centimeter. They exclude extensive cancer, multiple foci, or margin that is less than 5 millimeter. So here they compare whole breast irradiation, 50 gray, 25 fraction, with accelerated partial breast irradiation, 30 gray in 5 fraction every other day. So median follow-up is 10.7 years. At 10 years, cumulative incidence of ipsilateral breast tumor recurrence are comparable, 2.5% versus 3.7%. And ABBI has significantly less acute toxicity and late toxicity, and also improved cosmetic outcome as deemed by both doctors and the patients. Another APBI trial, so it's the HYPEP trial. So this one also a single center, recruiting from 2015 to 2018 for postmenopausal women, clinically node 0, unifocal, T1 to 2 tumor. They're comparing whole breast irradiation 40.5 gray in 15 fraction with SIB, simultaneous boost to the tumor bed 48 gray, versus accelerated partial breast irradiation 30 gray in 5 fraction every other day. Endpoint cosmetic outcome, median follow-ups 36 months. There are 5 local failures and 3 local regional failures, non-statistically significant between the two arms. In whole breast irradiation, there is increased incidence of overall toxicity and grade 2 acute skin toxicity. In APBI, lower incidence of overall late toxicity. So local recurrence rate is low and comparable between two arms. Acute skin toxicity and overall late toxicity are significantly reduced with APBI. So there are so many trials out there. Actually, there are rapid trials. There are NSABPB39, also many other trials of talking about hypofractionation and also reduced area, partial breast. Which one is safe for us to do? What do the guidelines say? So first, look at the ISRO consensus, Lancet Oncology. For the whole breast irradiation, 40 gray 15 fraction. When do we do that? Should be offered regardless of age at diagnosis. Pathological tumor size, breast cancer biology, surgical margin status, tumor bed boost, breast size, invasive CA or even DCIS. Even oncoplastic breast conserving surgery is also suitable with 40 gray 15 fraction, and regardless of the use of systemic treatment. So when can I use the shortened version, the 26 gray and 5 fraction daily? It can be offered as standard of care, or if you conduct a trial or in a prospective registration cohort. What about chest wall irradiation? Similarly, 40 gray in 15 fraction for chest wall RT without breast recon and regardless of time or type of breast reconstruction. 26 gray in 5 fraction is for chest wall RT without recon. So for reconstruction, 40 gray in 15 fraction is the one that you should use. So what about regional nodal irradiation? Only 40 gray in 15 fraction. And partial breast irradiation for low-risk group using EBRT, either way, 40 gray in 15 fraction or 26 gray in 5 fraction. So, and what does NCCN guidelines say this early year, January 2025? Whole breast radiotherapy, also similarly 40 to 42 gray in 15 to 16 fraction, or 28.5 gray in 5 fraction weekly for people who meet the eligibility criteria. For those frail patients that need radiotherapy, this 5 fraction weekly is very suitable for them. They can just come 1 time per week and yet still save and yet still receive adequate dose. For post-mastectomy radiotherapy, including with reconstruction, is 45 to 50.4 gray, 25 to 28 fraction, or the moderate hypofractionation, 40 to 42 gray in 15-16 fraction. RNI, similar to PMRT or whole breast radiotherapy. Partial breast using EBRT, you can use the 30 gray in 5 fraction or the 40 gray in 15 fraction. What about the FRCR from UK recommended? So in UK, adjuvant radiotherapy to non-nodal breast or chest wall without immediate reconstruction is 26 gray in 5 fraction daily over 1 week. Partial breast using external beam radiotherapy, also 26 gray in 5 fraction daily. Regional nodal irradiation, 40 gray in 15 fraction over 3 weeks. And in patients with comorbidities and frailty, making daily RT difficult, we can also consider 28.5 gray in 5 fraction weekly. So in summary, after so many trials and so many guidelines, so moderate hypofractionation, 40 gray in 15 fraction is safe. Ultra hypofractionation, 26 gray in 5 fraction, for example, is also safe for whole or partial breast or chest wall irradiation without regional nodal irradiation. Whenever RNI is required, whenever regional nodal irradiation is required, use moderate hypofractionation. Mastectomy with immediate breast recon, also moderate hypofractionation. Patient with autoimmune disease, collagen vascular disease, vitiligo, use moderate hypofractionation. So I think we need to adhere to guidelines and safe protocols to ensure we provide optimal target volumes coverage while minimizing the treatment toxicities for our patients. Thank you.